Okay. So this dog has both an adrenal mass and a left cruciate rupture. The adrenal mass is, the dog for all the world looks Cushingoid, but is negative on both low-dose dex and ACTH stim tests. So likely has a pheochromocytoma if that's what it ends up being, but it does have a lot of clinical signs consistent with hyperadrenocorticism, so not fully convinced that it's not. And the left adrenal mass is slightly adherent, or has her potential tumour thrombus into the Lisa Abdominal, maybe the caudal vena cava, and maybe the left renal vein. So we're looking at all those different possibilities, and if everything's going well, we'll do a left TPLO as well. I honestly think that's doubtful, but we'll see how things are going. Can we hook in the harmonic scalpel, please? I need more. Okay, so can I just grab a photo of this? Photo? You can probably go further away if you want. Okay, so this is I'm not sure if it's going to work or not considering the size, but this is a retractor that's used for video-assisted minimally invasive surgery. One of the lecturers in a recent trip to Romania showed me how to use this. If you can do another photo. So insert the grey ring into the exploratory, and then we're just going to twist this to tighten it up. I'm using this because I'm not a big fan of Balfours. They twist and turn on you, and this also provides some degree of protection from the abdominal cavity in the skin. If you do the other side. That's it. Again. Keep going. Again. So we can do one more. Okay, we almost got there. Yep. Okay, and come another photo. So. So you can see this is a very nice view. I think I'm convincing our assistants. So now we're just going to do our explore. Just hold that out gently there. Don't touch the pancreas. Okay, so that feels all good. Let's do the other side. Okay, so there's a adrenal mass just in here. So if you just get a lap sponge, get that left lateral out of the way. That's all I need. Can we have a medium malleable retractor, please? The larger ones, I think. Should have a size in between. Are being used or? Okay, hold that there. So there's mass. Let's just redo this. Oops, that didn't touch. Let's just try that. Can you zoom in a bit, please? Keep going. Okay, that's very good there. Is that in focus or? I don't have my glasses on. So this is a adrenal mass here. Kidneys behind this. I'm just going to work around this now. Let's switch the harmonic scalpel. I need to pull on this. Oops. Can I get someone to scrub in, please? And can I have the suction on as well? So this is not secured. So I'm just getting someone to hold this back for me so I can have better exposure of the adrenal. Because Shogo's holding back the liver lobe here and the kidneys here. So I'm getting good visualization. What I might actually do is, if you come around this side, I'll do my dissection from there. So you grab those, you hold those back. Thanks, Mel. So if you come this side as well, just want you to hold the kind of this back, like that's perfect. It's great. Thanks. So we've got that. We have my bakies over here. It's great. Another photo while we're here. That's the adrenal just in there. Great, thanks. So I'm just basically isolating the adrenal gland out of its retroperitoneal space, seeing where these vascular, the phrenicobdominal is and the caudal vena cava is in relation to it in the renal vein. Sometimes there's nothing like finger dissection. If you can contract it a bit more. Yeah, Mel. So if you can maybe hold up there. Don't know what's in here. Can I have the other malleable retractors? The small ones here. That fits there. Take it out. What is that? Let's take that for a sec. Let's hold that back there for a sec. So this is our caudal vena cava here. We have a thrombus coming down. That, I'm not sure you can see it, but that white thing I'm pressing there is the thrombus. It doesn't extend down into the cava. So we're going to get a Satinsky clamp around here to just partially block off the cava and give us enough of a cuff to remove the adrenal with all of that. I'm not sure whether this is from the right-hand view, so I'm going to see whether I can get it better from the left-hand view, but there was some soft tissue attachments which are making it a little bit more difficult. What's that? Yeah, see how it's moving around? Do that one. And then if I can have some 4O PDS on a tapered needle. And if I can have a photo, first photo will be better from this side, from Mel's side. Yeah, and if we go over to the other side. Stop. Don't. Okay, hold that back. Let's get these positioned again. Okay, got that. Kidney, so I should get that out of the way. I don't know what's in here, it's a problem. I'll take the photo regardless. Yeah, photo, thanks. Let me just grab this. Okay. Okay. Let's take that back and have a look. Show me. Let's take another one just in case. Yeah. No. Okay. Yeah, so I think we're going to have to approach this from the other side. So this is the adrenal here, and when I extend that out, I'll take that out. When I extend that out, you can see the this white section here. That's the tumor thrombus. That's the phrenic abdominal vein, and this is the caudal vena cava. I think this is a cranial mesenteric root here, so I'm not getting a good view of the cranial aspect of the caudal vena cava. So I'm going to switch over to the other side to do the rest of this dissection, basically. Okay, so yeah, let's just switch over. Hold, and maybe that like so, like so. Okay. So we've still got whatever that is, kind of anchoring us down. So this is the next question here. Looks like this might be the renal vein coming off the... so this is the phrenacoabdominal here. And then there's a renal vein, I think, coming off the phrenacoabdominal just there. So that there might be another thrombus in there. Actually, I don't know. That looks like thrombus there. So we may change our mind here because when I do this, you can see a little white part coming up here. So the thrombus might actually be extending into the caudal vena cava there. So can I have the Rummel tourniquets? The Rummel tourniquets, so the umbilical tape and the red rubber catheters.
There's 3 options over there. Is it 5 times okay?
I just need to be able to get it up there. No, they need to be big. Kind of the umbilical tape. So Matt, you know the plan. So the red rubber catheter needs to fit doubled over umbilical tape in the middle. They're way too small. Way too big. Way bigger. Yeah. Bring me the biggest one. Yeah. So now, instead of using Satinsky clamps, we're going to use Rummel tourniquets to occlude the caudal vena cava. The plan is still to do a cuff around the phrenacoabdominal vein and just close that afterwards. But the Satinsky clamp won't work because of that tumor thrombus that's gone through the phrenacoabdominal vein into the caudal vena cava. And some right-angled forceps as well. So I'll need 2 of those. Oh, will they? No, that should be okay. And you know the wire passer? Not the wire passer, the little hooky thing. There's a wire that you put down a tube. It's got a hook on the end.
It's in the drawer. It's in the stock room in the same package area. It's on the wires. Or in the top area. 1, 2, 3, third. To the left, bottom drawer. It has a wire. You have to pick up this. Isn't it?
Let's grab right-angled forceps after that. So now I just need to dissect the soft tissues around the caudal vena cava in its entirety to be able to pass the umbilical tape for the Rummel tourniquets around. And then we'll work on getting that out. Yeah. Mm-hmm. Okay.
Normally we've been giving them like 5 to 10 days.
Why do they have more? Like it's permanent, so whatever they want, day-wise, because it's lifelong treatment. Thank you. No. No. No, it's none of those. I don't know what it's called, but it's just a wire thing that you put down. It's got a hook on the end, and you just
Oh, like a full, like it was not at the base of it. Not a full circle. No. So like not, we don't want a guide wire?
no.
It's like a guide wire, but it's I think it's in the bottom drawer, third to the computer is below, third bottom.
What's that?
As soon as you lean forward, the view.
Yeah. Show it. You don't need to hold that. I want. There's a wire thing that you pass down through the lumen here, and it's got a hook on the end that you bring the umbilical tape through. So it goes down through there.
We did it
We
once
do.
with Jesse. It was a few months ago, and it was a turned wire with like a jib base of it.
It's a J hook or?
I think so, yeah.
Like a
It's
grasp.
a jib hook.
It's definitely not a grasper. It's just a hook. I've got a photo piece. Okay, another one like so. Okay, I'm just gonna end that. Okay. So that's the cranial one done on the caudal vena cava. Pass me the umbilical tape. This is just the right renal vein that we're coming under. Put a rummel on this as well. What's that?
Your camera is still blocked.
Yeah. Can I have another umbilical tape, please? Yeah. Thanks.
strong enough to do what you want to do, then me.
No.
Is it in a package? Like, were you there when?
We had this thing
Is-
happen last time. Jesse knows exactly what it is. Like, I thought it was that as well. And then I also thought it was like, it's one of the catheters that comes with the vascular.
Just get Jesse out of the console. If I can have another photo, please. Maybe a bit more over the top and down. No, sorry, it's not focusing. Yeah. Okay. So what we have is the umbilical tape cranially around the caudal vena cava, caudally around the caudal vena cava. This is the phrenaco-abdominal vein to the left adrenal gland, left renal vein here, and right renal vein here where we have another rummel tourniquet on. We just need to get an instrument to be able to pass the umbilical tape through the red rubber feeding catheters to create the rummel tourniquet. I'm just having a bit of difficulty finding that. How are we going up there? Yay.
You already showed it this one.
No, I don't think so.
It's just the speaker passing one.
Oh.
I was picturing a protein too.
Thank you.
I thought it was
suture passing thing sounds good.
No, but this whole with
The Rummel tourniquet.
oh,
The Rummel tourniquet.
Rommel.
So there's not an adrenalectomy thing in our equipment list. So, well, maybe describing that as well.
Umbilical, the largest red number, and this is really it's like we went through this scenario a few months ago.
Do we have smaller umbilical tape? This seems quite big.
We need potentially, I know at one point it used to be on back order. Can you think of a thinner umbilical tape?
Yeah, this is very big. I don't think I can get that through the loop. Yeah, perfect. So, thanks. Okay, so we're just going to replace this kind of thicker umbilical tape with the thin one, which is going to work better. No, that should be enough. And my debakey there. Actually, no, you're right. Cut. Thanks. Okay, round two. Shut over there. I'll pass it around first and then cut it. If you need to help me here, Shogo. That's good. Good. Let's just put this one on. Just hold that there. Well, 2 more lat sponges, please. We've got some blood welling up here. How are you doing? What's that? How are you going on your end? Okay.
Just need to 5 more lat sponges.
Bakies and umbilical tapes here. Okay. Can you zoom it out more? Yeah, that's good. Thanks. Use that. Okay, so now we have a Rummel tourniquets. This is cranial, this is caudal, this is on the renal vein. Can you switch it 180? Yes. A bit more, that's great. So cranial, caudal, renal vein. If I can grab a photo. And then what we're going to do is just do a incision around the phrenico-abdominal vein entrance into the caudal vena cava and extract the tumor thrombus. It's going to be a little bit complicated because I wonder if I can get that. Just come out. Just going to see if I can get the adrenal tumor onto this side. Yeah, there we go. Let's go. Okay, so I've got the adrenal tumor now on our side, so this is going to make things easier. Can I grab another photo, please? And maybe one angle just a little bit. And angle it down there. Yeah. Thanks. Okay, so it's time to prepare for this now. This is kind of the scary part. So if I'm abrupt with anyone, it's not personal, okay? So essentially we have maybe 8 minutes occlusion time. I have this all loaded up. Got this here. Don't need those. That can be for you. Actually, use that one instead. So this is a complicated surgery. We have our anesthesiologist here and anaesthetist here. They're in here the entire time. This is likely a pheochromocytoma, so there's a whole lot of catecholamine things going on. So on that end, I don't know if they're stressed, but they're certainly well aware of things. On my end, we've got ideally less than an 8 minute occlusion time, so we're going to be counting that. And then have to manage bleeding and everything else. So the Rummel tourniquets will help, but this is not an easy peasy surgery right at this stage. So what I'm going to do is close down the caudal Rummel tourniquet first. I need to slide down the red rubber catheter against the caudal vena cava. I'm now going to do the renal vein. Slide down that. And lastly, the cranial aspect of the caudal vena cava. Trying to keep that as cranial as possible so I'm not cutting off the tumor thrombus. So you can see that that cable segment kind of welled up then. So now I'm just going to do incision around the yeah, I'm not sure about that one. Have that ready. So everything's occluded, guys. Suction. So my venotomy is complete. So that's our tumor thrombus. I'll show you afterwards. Now it's just time to close up this venotomy. Suction. I can't see it's here. I still can't see. So, you're in the way, Shogo. Okay, you're still in the way. Out of the way. Out of the way. Out of the way. Get out of the way. Still in the way. Okay, just down here. Yeah, good. Okay. Okay, what up there? No, you. Okay, that's all vascular one. Okay, so I think I've got it, but it's a little bit hard to see. So I'm just going to release this caudal ramal tourniquet, see if there's any blood filling up. There's something coming there. Oh, damn it. Where's that coming from?
In the portal to the
Portal? Okay, that might actually be the renal veins.
Yeah, you got it.
Okay, so that's something else.
No, something else isn't coming.
Okay. Okay, we're releasing. So you always release from the caudal to cranial direction. It's a vein, so you want the to avoid an air embolus, which is not that common anyway. You want to fill the segment up before it moves cranially. So our only issue now is, I think, our renal vein. I'm just getting the ramal tourniquets off because that's working well. It's okay, these are traveling pretty naturally. Okay, that's off. Can I have the Liger clips, please? The small Liger clips. Thanks. Thank you. Go higher up than that. Put one there. Okay, so that's under control. Can I have another photo, please? How are we doing? Okay. Okay, thanks. Okay, so let's just have a quick look at this kidney. That kidney still looks pretty good. Let's come out. So there's no congestion in that kidney, so that's good. We should do renal values again tomorrow morning, but that's all good. Ron, did this dog have elevated liver enzymes? Okay, so let's take a... what is that? Nothing major, but yeah. Okay. So that's it. Just going to get this out now. Remove that. If we can have the... you're all good. Thanks for your help. 2.0 PDS, 3.0 monocryl, and 3.0 nylon, please. One of the renal veins, as in it might be the only one, but right now it's looking okay. Yes. Thanks. Can you turn off the suction, please? I'm going to make a call on the TPLO. I'm not doing it. Sorry. I'm going to make a call on the TPLO. I'm not doing it. Yeah. Sounds like you're holding your breath for the entire time there. They're exciting, but they're stressful.
Whenever you see the thrombus, and then when you put the adrenal gland, the thrombus comes with the adrenal gland.
Yeah. Yeah.
So it shouldn't be separated from the adrenal gland.
No. Actually, the one thing we did not do was count lap sponges. I've got 4.
Yeah.
Yeah. Okay, so you can finish up the 3.0 that. So Shoga's going to finish up. We're going to do a skin layer on this just in case this is a Cushingoid dog. And we just need that extra security. This is, just to give you a view of this, this is the adrenal tumor. The adrenal tumor itself here, and then the tumor thrombus that went through the phrenico-abdominal vein into the caudal vena cava. So it wasn't a huge one, but it was enough that we needed to go into the caudal vena cava. And so I'll sign off while Shogo finishes up.
We both check this for this.
Yeah.
Post-op delivery, 61 today.
Yes, please.
For exam, putting fentanyl. She did have a FS block for that left below.
Okay.
Samples that are going out.
Adrenal.
Left.
Yeah.
Okay, and my skeletal is.
Oh, let's turn that off. Are you doing the timing for the scalpel?
No, just. There you are.
Oh, you here? Yeah, thanks.
You already put your stuff in your front form for the sample.
Yes.
Excellent. Estimated blood loss, I have 200 mils on this side.
I think that would be close to it. We've just got one full one and the rest are pretty minor. Yeah.